That concludes our anterior abdominal wall and inguinal region discussion. In the next session, we'll talk about the abdominal cavity and its Falcon and Physician Reviews on the online anatomical review. We're now at section 26, and we're going to look at the abdominal wall and the inguinal region. Going back to anatomical landmarks, here you can see the anterior abdominal wall divided into the 9 segmentations, which you should be aware of. And there'll be a subcostal plane, which goes under the costal margin, and the transtubercular plane, which will go across the top of the iliac crest. And then you have the 3 components on the left, which would be the left hypochondriac region, left lumbar, and left iliac portions. Then in the midline, you have the epigastric, umbilical, and hypogastric portions. And over on the right, you have the right hypochondriac, right lumbar, and right iliac components. You may also need to be prepared for the fact that most times now you'll hear right upper, right lower, left lower, and have it divided into quadrants. But I think you'll need to be familiar with both of these for referencing in some of the case scenarios. Not necessarily with anatomical questions, but with some of the other course questions as well. So superficially, we have the abdominal wall divided into 2 portions with that superficial fascia, having the Camper's fascia on the outside and the Scarper's membranous fascia, which is more complete from the umbilicus down. And that Scarper's fascia will actually go down into the fascias of the groin as well. So we're going to come back to that when we talk about damage to the urethra a little bit later on in pelvis. Let's do a question. A 50-year-old woman is brought to the emergency department because of severe upper abdominal pain for 24 hours. She has a 2-day history of intermittent fever and pale stools. Her temperature is 38.9 degrees Celsius, 102 Fahrenheit. Pulse is 120, respirations are 20 per minute, and blood pressure is 90/50 millimeters of mercury. Physical examination shows jaundice and tenderness of the right upper quadrant of the abdomen over the costal margin. Serum studies show a bilirubin concentration of 5 milligrams per deciliter, alkaline phosphatase activity of 450 per liter, and lipase activity of 400 units per liter. Which of the following is most likely the cause of this patient's symptoms? This should immediately get you thinking of referred pain, also the regionalization in the right upper quadrant over the costal margin, and this could be something from obstruction of the gallbladder or a stone, since they have problems with both bilirubin, alkaline phosphatase, and lipase activity. This is more likely to be a blockage at the hepatopancreatic ampulla. In this slide, you can see the referred pain from the abdominal viscera is distributed over with the gallbladder from the anterior view projecting to the costal margin on the right side, and sometimes around to the inferior angle of the scapula. So when you think about referred pain and these 9 components of the anterior abdominal wall, here you can see the epigastric, which will be referring to stomach, duodenum, and pancreas head, with the right hypochondriac going to the gallbladder and liver, left hypochondriac to the spleen and stomach, and then the umbilical and hypogastric regions with the appendix, the cecum, ascending and sigmoid colons. And in the lumbar and back regions, you can see kidneys, ureters, and liver, and stomach, gallbladder, and diaphragm. The subcostal plane, which will be through the lowest costal margin, is through the level of the L3, and sometimes L2 if you're young. The transpyloric plane will pass through the pylorus and is at the level of L1. And the transtubercular plane will pass through the tubercles of the iliac crest at L5, with the supracristal plane drawn through the iliac crest, taking you through L4. When we look at the musculature of the anterior abdominal wall, we know we have the flat muscles, including the rectus abdominis down the midline, separated by tendinous intersections and linea semilunaris, as well as the linea alba down the midline. And then we have the flat muscles, the internal oblique, the external oblique, and the transversus abdominis muscles, which are organized the same way that the intercostal muscles were. All of these become aponeurotic as they start forming the rectus sheath around the anterior wall of the abdomen. They're innervated from T6 through L1. If we look at cross-section in this next slide of the rectus sheath, you can see that there's two components. There's those things that are above the arcuate line, and there are those things that are below the arcuate line. If you look at those above the arcuate line, with the linea alba in the middle and the rectus abdominis in the middle of the rectus sheath, you can see that both anterior rectus sheath and posterior rectus sheath are split by the layers of the aponeurosi coming from the three flat abdominal muscles. There's always a transversalis fascia that runs posteriorly, and then you have the extraperitoneal fat and parietal peritoneum. Below the arcuate line, however, the rectus sheath goes anteriorly, so the anterior wall is quite thick, which leaves a deficit or a thinness at the posterior abdominal wall, and that will become clinically relevant when you start discussing the opportunity for bowel to herniate out. So let's think a little bit about hernias. One of the more rare hernias is a Spigelian hernia, and this is extrusion of the abdominal contents along the edges of the abdominal wall at the level of the linea semilunaris. And these are basically going to be due to an incomplete closure or open fascicles in between the aponeurosi, where they get thinned out. And they're always going to be lateral to the epigastric vessels, the inferior epigastric vessel, and they'll typically be below the arcuate line. And it's that arcuate line that's the designation difference between the various layers of the rectus sheath. Here you can see a CT of a Spigelian hernia coming through and getting in between the layers of fat and the abdominal musculature. Umbilical hernias are also going to be something that will be common and can be tested on the USMLE. They get divided out by age. The congenital hernias are divided down by size and age. If it's less than 2 centimeters, you can watch it, and they'll usually spontaneously close by the age of 3 months to 1 year. If it's greater than 2 centimeters at the age of 4, then you're probably going to need to repair it. They tend to be more common in Afro-American babies, and to prevent complications with umbilical hernias, if they don't disappear by age 4, then they'll need to be surgically repaired, or if they appear during adulthood. Most of the adulthood hernias that appear oftentimes are post-surgical. The inguinal canal is a tunnel for passage of structures that going through the abdominal wall. For the males, there's spermatic cord, and for females, it's the round ligament of the uterus, which is the adult form of the gubernaculum. And in females, this will attach into the skin of the labia majora. Now, some of these things through the inguinal canal will have to push through some layers, and then they'll pass right through where there's a partial opening or a full opening. In a way, it's similar to having a doorway that you don't have anything to push through, or putting some saran wrap across that door and then needing to drag it as you walked through the door. So these are going to have some things that pass through the openings and some things that don't. The anterior wall of the inguinal canal is going to be formed by the aponeurosis of the external abdominal oblique, and it's going to form the floor, which thickens up as the inguinal ligament. The posterior wall and roof are going to be from the abdominal muscles that fuse together, which would be the internal abdominal oblique and the transversus abdominis. On this slide, I've got a comparison of what the anterior abdominal wall structure is and what it becomes if it's contributing to the spermatic cord. Here you can see the external abdominal oblique aponeurosis becomes the external spermatic fascia, internal abdominal oblique becomes the cremaster muscle. Transversus abdominis is not involved in the spermatic cord at all because it has a deficit in it, so nothing drags it out through onto the spermatic cord. Transversalis fascia is dragged out as the internal spermatic fascia, and the parietal peritoneum, which will have a component of it pinched off to make the tunica vaginalis around the testis and give the testis a half of a serous sac. The cremasteric reflex is going to be a contraction of the cremaster muscle, which is again a component of the internal abdominal oblique muscle, that will cause the testicle to elevate on the stimulated side. And it's the genital branch of the genitofemoral nerve that innervates the cremaster muscle, and this is an L1 reflex. Here's a question. A physician, while surgically exploring a hernia on a 34-year-old male, observed that it began just superior to the inguinal ligament and lateral to the conjoint tendon. What type of hernia did she need to repair? In this case, you'll be looking at a direct inguinal hernia. Oftentimes, they'll discuss the inguinal ligament, and it has to be above it to be an inguinal hernia, and if it's below it, it would be femoral hernia. If it is a lumbar hernia, it would be posterior abdominal wall, and an indirect and direct are the only two that you have to choose from. In this case, the conjoint tendon was labeled. Oftentimes, they will either discuss the inferior epigastric vessels, but I think the conjoint is also a useful structure for you to have an awareness of where that is, and we'll see where that is in a few moments. Here, the inguinal triangle can be seen from the internal surface of the anterior abdominal wall. So we are looking on the abdominal wall from an internal view. Now you can see the conjoint tendon labeled towards the medial side, and it's coming down as the fusion components of the transversus abdominis and the internal abdominal obliques, a aponeurotic connection down to the pubic tubercle. Then it will sweep under as the lacunar ligament when it goes under the inguinal ligament. Based on the last question we did, the important thing that I want to point out on this slide is that if you're lateral to the conjoint tendon and above the inguinal ligament, you'll be a direct hernia. If you are inferior to the inguinal ligament but lateral to the lacunar, you'll be a femoral hernia. Now, the inferior epigastric vessels are also going to be an important landmark because you can see the deep ring, which is going to be lateral to the inferior epigastric vessels. So for an indirect hernia, you have to be lateral to the inferior epigastrics and above the inguinal ligament. This triangle that has the medial side of the inferior epigastric, the rectus abdominis, and the inguinal ligament as its boundaries is known as Hesselbeck's triangle. Here's another view of the abdominal layers and the things that contribute to the spermatic cord, and you can see that the peritoneum is going to be pushed through, the transversalis fascia is going to be pushed through, and then there's an imperfection in the transversus abdominis muscle so that there's no need to push through that layer and have it represented in the spermatic cord. Then you can see the internal abdominal oblique, which does get some fibers pulled out as the cremaster muscle, and finally the fascia of the external abdominal oblique will form the external spermatic fascia over the spermatic cord. So it's that imperfection in the transversus abdominis that forms the deep inguinal ring. In this view, you can see a hernia that is heading through the deep ring just lateral to the inferior epigastric vessels, and it will present by coming out through the superficial ring underneath the fascias of the spermatic cord. Unlike a direct inguinal hernia, which will push directly through the superficial ring, but will not be covered by the layers that you see covering this indirect hernia. So the indirect hernia has a circuitous route that goes through the deep ring, along the inguinal canal, and then out through the superficial ring. A direct inguinal hernia will push lateral to the conjoint straight out through the anterior abdominal wall and out through the superficial ring. It has a more direct path. Here you can see an inguinal hernia that is marked with the medial side of the inferior epigastric artery and vein, making it a direct hernia. The other one that you can see the skin bulging through is an indirect hernia. Now, of course, you can't tell this just by looking at this superficial surface drawing of the picture of the abdominal wall, but through inspection you could tell that this was an indirect hernia. Indirect inguinal hernias are through the deep inguinal ring, inguinal canal, and then out through the superficial inguinal ring, and they are within the coverings of the spermatic cord. The congenital form of these indirect inguinal hernias are persistent processus vaginalis tracts, which allow a serous fluid to keep the tract slippery, and that way it makes it easier for the bowel to progress along that tract. They're more common than direct inguinal hernias, and they tend to be even more so common in males who are newborns. As far as a direct inguinal hernia, it passes below the falx inguinalis, directly through the abdominal wall into the superficial inguinal ring. They will tend to be medial to the inferior epigastric vessels, and they will not be within the coverings of the spermatic cord. They rarely descend into the scrotum, but they certainly can descend into the scrotum. They occur primarily in older males and rarely in females when the conjoint tendon is weakened in the inguinal triangle. Note that the different types of inguinal hernia may not be distinguishable on the typical turn your head and cough exam of a physical exam. Let's move on to testicular hydrocele, which is a result, as you can see here in this young African boy, a result of a persistent tunica vaginalis, which will allow the bowel to head down and into these areas, but it will also be a collection site for simple fluids since it's a serous sac, and that can produce a hydrocele. And this young man has a testicular hydrocele as a fluid-producing serous sac. If there's cord-like obliterations on one side or the other or both of the processus vaginalis, you can end up with a fluid-producing hydrocele which will collect fluid and may need drained or operated on. Another formation of the male anterior abdominal wall is that the testis descends down through the end of this spermatic cord as well. And if the testis does not descend fully, which we'll talk more about the development of the testis and the gonadal system a little bit later on, but it makes sense now to talk about an undescended testis, which is a resulting factor called cryptorchidism. Orchid is the testis, and the crypto is meaning that it's within. So we have 30% of male preemies that will have an undescended testis, which is normal because the testis typically doesn't start descending until the 37th or 38th week. About 5% of male babies that are carried to term will have an undescended testis, but only 1% of them will end up having this by the first year. It is necessary to treat these, though, because at the higher temperatures it can inhibit normal sperm production through spermiogenesis and result in infertility. Also, and more importantly, an undescended testis is more susceptible to cancers and tumors. An empty scrotum can cause some worry and some embarrassment, so those are other issues on why you'd want to go in and operate on these to get them descended. There's a couple more testicular problems that we should discuss. One is the testicular varices, which is an engorgement of the pampiniform plexus of veins, and they produce a scrotal mass as they become dilated. They are typically on the left side, which may indicate that there's some problems with the kidney, because the kidney disease and the retroperitoneal malignancy may obstruct the drainage of the testicular vein, or they can be rapidly developing as a result of a renal tumor. Torsion of the spermatic cord is an incredibly painful twisting that occurs around the testis itself because of the gubernaculum testis becoming unhitched, and it can lead to testicular necrosis and death of the testis within 12 hours. It does require a surgical repair by untwisting the cord in the scrotum by cutting into the scrotum. It will usually be associated with vigorous exercise in the stem of questions that are leading you that way, and typically between 10 to 20-year-olds. It's oftentimes the absence of that scrotal ligament that will allow it to twist around. The spermatocele is a fluid cyst that occurs within the head of the epididymis, and it can become a blockage which will get a cyst-like collection of fluid. They can be asymptomatic unless they're accompanied by an inflammation of the epididymis itself, or epididymitis. The epididymal cyst may cause infertility as well. Testicular cancer spreads to the aortic nodes through the lymphatics accompanying the testicular artery. Since the testes have descended from the abdominal region near the T10 dermatome, this can pass the testicular cancerous cells back through the lymphatic system quite quickly, and you can have a metastasis of this quite quickly.